everyone. Welcome to another Wednesday VMR. I am super excited because I get to learn from Prof. Rez today. How's it
Whoop,
going, Prof.
whoop.
Rez?
Hi.
Prof. Rez, that's like the lowest energy high I've ever seen you do. We're super excited to discuss a case by Sam. And thank you so much to Julia and Amalpreet for doing scribing and teaching points. Sam, do you want to say hi?
Hi everyone, I'm Julia. I will be describing today, and I'm so excited for Sam's case.
Thanks so much, Julia. Yeah, Sam, we're super excited. If we can get the board up, then we can get started. Um, awesome. Professor, I'm getting a call. Would you mind taking the first aliquot?
You got it, of course.
Yeah.
All right, Sam, how's it going?
Good. How are you?
Well, tell me a little bit about yourself.
Well, I'm a relatively new CP Solvers person, but I'm a fourth year med student. I'm from Maine. I'm a student at Tufts University, and I'm planning to go into emergency medicine.
Oh, that's phenomenal. Well, very excited to have you. Looking forward to discussing your case.
Yeah,
Emergency medicine doesn't help narrow because it could be anything that you present us.
well, and this is from one of my other rotations that was not emergency medicine, and I'm not
Got
going to
it.
say which one, but
All right.
I think you'll see pretty quickly.
Okay. Please, whenever you're ready.
All right. You ready, Julia? All right. So for our first aliquot, we have a 35-year-old male. He's presenting with 4 weeks of headache and 2 weeks of double vision.
Yeah, I really love this. And I love where you decided to make a pause because we already have like a striking finding, which is double vision. And for now, I'm going to ignore the headache and focus on the double vision because whatever is causing the double vision is also causing the headache. Or another way to put it is that the double vision will lead to a narrower and more crisper differential diagnosis. And so whatever is causing the headache is also causing the double vision. And I think with double vision, you have to be very clear that you're not dealing with blurred vision. And in fact, the patient is seeing two. And the reason that's important is because blurred vision is often due to issues with refraction. And back in the day before I got LASIK, I wore glasses, and if a patient told me they had blurred vision, I would give them the glasses to see if it would improve the vision quality. But it's likely this patient has double vision. And then the next branch point is going to be whether it's in a single eye or in both eyes. And what I mean by that is that if you close the eye, either eye, and the double vision resolves, then you can be certain that you're dealing with binocular diplopia, meaning you need both eyes open to have the double vision. And that translates to a problem with extraocular muscles. Now, if you close the eye and the double vision persists, then you know you're dealing with monocular diplopia. And now all of a sudden, the focus goes from extraocular muscles to the actual eye itself, whether it's the lens, whether it's the retina, whether it's the optic nerve. I think it'd be too premature to share a differential diagnosis until we confirm whether we're dealing with binocular, both eyes open, double vision versus monocular, single eye open, double vision. And if you incorporate the 4 weeks, I think like the tempo is really helpful because it allows us to say, hey, this problem is more subacute to chronic, which really lessens the likelihood of a stroke, for example, which is sudden and abrupt in onset. And that's, I think, it's really, really helpful to like say this is not hyperacute or sudden, but more on the subacute, which will also inform the differential diagnosis. Sharmin, anything else to add before we get more information?
Oh no, that was beautiful. I was like, I keep forgetting, Professor, that you're a neurologist and an ophthalmologist too. um, awesome.
Sharmin, I'm barely an internist, so don't say that.
Too humble, too humble. All right, Samantha, back to you.
Okay, you'll have to let me know how LASIK goes. I might try to get it in a couple years. When I'm not in, crushing student debt anymore. So for a second aliquot, I have some further information about the history of the present illness. So the headache that started 4 weeks ago, it is left-sided only. It's of stabbing quality. It's located behind his left eye and kind of radiates down to his neck. It's associated with some watering of the left eye. It comes in episodes that last between a few hours to lasting all day. He feels it's been somewhat improving over this time course, but has never really gone away. The pain partially responds to high doses of ibuprofen. He's currently in 3 out of 10 pain. And then he adds that about 2 weeks ago, his fiance told him that his left eye was not moving when his right eye moved. He says the double vision improves when he closes his left eye. He denies photophobia, phonophobia, positional changes to the headache, fevers, unexpected weight changes, any other infectious symptoms, joint pain, or significant stressors in his life. He's not having any frank pain with his eye movements. And then he contacted his primary care provider, who recommended he come to a tertiary care facility for evaluation by the neurology team. For some additional past medical history, he has ADHD and autism spectrum disorder, but he's otherwise healthy. His only medications are Adderall, ibuprofen, and magnesium supplements. He denies having any allergies. He does rarely use alcohol, but he does not use nicotine or marijuana. He has 2 cups of coffee daily, and he occasionally consumes energy drinks as well, and he notes that these have had no effect on his headache. He lives with his mother and his fiance. He's not currently working. He's on disability due to his mental health issues, but he's independent with all activities of daily living. He spends most of his time doing sort of construction projects around the house. There's also 5 rescue cats in the home, as well as several chickens. And as far as any family medical history, his maternal grandfather did have a stroke, but everyone else has been otherwise healthy.
All right. Maybe I'll just like tackle a bit of the HBI and then pass the mic to Prof. Rez as well. Yeah, I think I I agree with kind of the framing that Prof. Rez had. Is that for me again, like the diplopia is the most important problem we're trying to solve with the the headache, the being unilateral, the tearing invokes like a cluster type of headache classically. However, a couple of questions is like, has this ever happened before? And I think in the context of diplopia, I'm more likely to want to make sure we're not dealing with a secondary headache and then land on the primary headaches as like a diagnosis of exclusion with like migraine clusters. The most important thing we need to do is like explain the diplopia. And the fact that like one eye is not moving really makes it, as a Professor was making the distinction between like binocular or monocular, makes the binocular vision, the misalignments more likely. And whenever I think about like kind of binocular vision, like eye misalignments, there are like a couple of things that can happen that cause misalignment, right? One is like entrapment, if there's like any, or like if, and that tends to be sequela of a trauma, which we don't hear, like or orbital wall like fracture. The other one's like masses, which is like cancer, autoimmune, those things that cause mass effects. Most oftentimes we're dealing with weakness, and that kind of, and when you think about weakness, kind of like thinking about like your neuroaxis is like, is there like a brainstorm? 4 weeks would be like kind of more of a subacute, less likely than an acute. However, he might have had a stroke at that time that we think that he just didn't present for it. The other things like a PCOM aneurysm can press on the nerves, causing kind of a misalignment as well. And then the other things you also want to think about are the muscles itself, like kind of are we dealing with like a myasthenia gravis type of syndrome? So those are like kind of the first things that I kind of think about kind of where to localize it. Um, and in terms of like the rest of it, the rest of like a review of systems. I think like exam would be really helpful, and I think the neuroimaging would be informative here. But I'll like pass on the mic to Prof. Rez if anything else in the HBI caught his eyes, and if anything in the past medical history caught his eyes.
Oh, I think that's such a beautiful approach, Charmine. Makes it really simple to at least have a good approach to this problem. Now, what I'm going to do is, many times I've seen diplopia, but I haven't seen it with headache. So I wonder, and like when we reflect on this case, like how strong of a signal is the headache to the cause of the diplopia? But the fact that, like, of course, if someone has diplopia, they can have a headache, but this is like very focal headache right in the eye that's not moving. So when we go through the schema that Charmine shared, is it, the brain, the peripheral nerve, the junction, or a space occupying lesion? Of all those etiologies, for me, like the one that gets prioritized is the space occupying lesion, just because of the headache. For example, like I don't imagine a stroke to come up with a headache. I don't imagine variants of Guillain-Barré to have headaches. Myasthenia shouldn't have headaches. Uh, Thyroid problems really shouldn't have headaches. So I'm very curious to see if this is a very strong signal when you overlay focal stabbing headache to the eye that's involved that's not moving, where that really prioritizes the mass. But I'd love to learn once this case unfolds, like what the diagnosis is. But yeah, we're ready, Sam, for that physical exam, my friend.
All right. So for his physical exam, his vital signs, his blood pressure is 124 over 63, heart rate is 68, temp was 98.2 Fahrenheit, respirations were 18. He has a BMI of 36. He's generally well appearing and he's in no acute distress. His head, ear, nose, throat examination, notable for some mild ptosis of the left eye, has some surrounding erythema and clear discharge from the eye, but there's no conjunctival injection, no scleral icterus. The neck is supple with a normal range of motion. There's no jugular venous distension or carotid bruit. His pulmonary exam was normal. His cardiac exam was also normal. Abdominal exam is normal. His extremities are negative for clubbing, cyanosis, or edema. His skin shows no rash, no pallor. Neuro exam. I think this is the one you're all waiting for. He is alert and oriented ×4. There's no dysarthria. His language comprehension and fluency is intact. His visual fields are fully intact to confrontation. The pupils are equal, round, and reactive bilaterally. The right eye has normal extraocular movements. There are complete absence of all extraocular movements from the left eye. And there's mild ptosis of the superior palpebra. His cranial nerve exam is otherwise normal. There's no pronator drift. There's no abnormal movements. He has full strength to all tested domains. He has normal deep tendon reflexes throughout. His sensation is intact throughout. There is no ataxia, and his gait is normal. His psychiatric exam, he is noted to be euthymic. His behavior and thought content are normal, and his insight and judgment are intact. And I have some basic initial labs for you. His CBC, CMP, CRP, ESR, hemoglobin A1C, lipid panel, and serum ACE activity are all normal. And his PCP had actually ordered a head CT before they sent him to us, and that was normal.
Wow. A lot to unpack here. Maybe I'll tackle the exam, and then Charmaine, you can like add to the exam and interpret the labs and imaging. But I just want to tell Sam, do you go by Sam or Samantha? What do you prefer?
I go by Sam. I'm very short. It's hard to tell over Zoom, so I use a short name.
I was going to say, Sam, LASIK is something I highly recommend. And you can use your FSA and HSA like once you get a job. But of course, you want to make sure the vision is stable for some time. But it's like unbelievable. Like you wake up and you're like, wow, I don't have to use lenses or glasses. Um, yeah, it's really, really good. Okay. So this exam is really cool because you basically, if we can start backwards, and what I mean by that is like what moves the extraocular muscles, because Sharmin said this is an issue with extraocular muscles, and that's verified by Sam's exam. What cranial nerves are involved? Well, it's cranial nerve 3, 4, and 6. Where are these nuclei? Well, if Aaron was speaking, he'll tell you the specific location, but since Sharmin and Reza are speaking, we're just going to say the brainstem. And where does the input get to the brainstem? It comes from the motor cortex. The contralateral motor cortex goes to the brainstem nuclei of CN3, 4, and 6, which then send the signal to the extraocular muscles for movement. But it's important to note that the cranial nerves, especially 3, they have more function than just eye movement. And something that cranial nerve 3 is involved in is keeping the eyelid elevated. So it doesn't surprise me that there is ptosis on that left side. So the question then becomes, how can you knock out all 3 extraocular muscles? Because that's what Sam is saying. There's no movement whatsoever. 3, 4, 6 are all out. If you think about it, if you had a lesion in the motor cortex, right? I just can't imagine how strategic that lesion can be to just take out the extraocular muscles and not involve any other part of motor function. Also, I can't imagine any lesion in the brainstem. Like, it is true you can have a brainstem stroke that involves like 1 cranial nerve nuclei, but to involve all 3 cranial nerve nuclei. So if there was a lesion in the brainstem and the brainstem is so small, I would imagine it would affect other, motor and sensory symptoms. And when we talk about a demyelinating lesion, why would it just involve those 3 on the left? So all that is to say, everything is yelling that something is impairing those extraocular muscles from moving. So again, like the exercise is it the motor cortex? Is it the brainstem? Is it the peripheral nerves? Is it the junction? Is it the muscle? I think the easiest way to explain all this is something that is impairing movement, like a mass of the muscles. I can't imagine a lesion in the cortex and the brainstem or even at the neuromuscular junction. Now, all that being said, there is a CT scan that we have to reconcile, and I'm sure I'll learn something from this exercise. But I love the challenge so far. Mike, to you, Sharmizi.
Yeah, super fascinating. And Aaron would be very proud of Prof. Res. Yeah, and I think like the interesting thing is also that the labs are pretty unremarkable, at least like, you would assume like if there was like an inflammatory, maybe you would say ESR elevated, but if it's only like inflammation involved of like the brain and cranial nerves, you might not get any systemic sign of it. And as Prof. Rez like eloquently put, it seems like very isolated to one area, and that is like your like extraocular movements in the left eye. So I'm not surprised that the labs are within normal and non-con head CT. I think like non-con head CT is great for like big bleeds, big masses at times, but I think what you really need is like an MRI to kind of like better characterize. And I think like the question is like what type, and that's when you're talking to radiologists would be really helpful, because even though I agree, like it would be really odd that brainstem only affects have like such a localized effect. You probably want to still be able to capture the brain stem. So that would be kind of my next thing is like thinking about the MRI, and also call our really friendly neurologist as well, to kind of help us make more progress. Because I also agree, I think this is like a little odd. And the other thing that I was wondering if there's any where does this all cranial nerve, again, it's been a while, like the pathway that they travel to get to the eye, and if there's anything like closer to the left eye that could put pressure on all these cranial nerves. But then again, it would be like kind of odd that it would cause only this effect. So I think like, cavernous sinus or somewhere else along the way that the tracks are there any place that the two tracks are close enough to cause it? And it's interesting that like the pupils are not affected because like the parasympathetic runs outside. Correct me if I'm wrong. I'm really reaching deep. The parasympathetics run outside the cranial nerve 3. So the fact that that's not affected makes mass effect a little less likely. Sometimes like oftentimes like a single, if it was just like isolated cranial nerve without without any pupil, a lot of the times like microvascular like from diabetes or something tends to be the most common. But again, like I've never heard it hitting 3 cranial nerves at the same time. So yeah, I am very intrigued by this case, Sam. Anything else to add, Prof. Rez, before we move on?
Nothing to add, just a thank you for mentioning like the cavernous sinus. Definitely, I don't have like a robust script for that, but the fact that you mentioned that would make me, when you get that MRI, get an MRV as well, just to see the venous system. But yeah, thank you. Nothing to add.
All right. I love this localization. And similarly, we had no idea what was going on when we were doing this. We were very confused about everything you guys just mentioned. So now I have some advanced labs for you. We ran an anti-nuclear antibody, rheumatoid factor, a tick panel, because we are in Maine, and syphilis serology. It was all negative. We did a repeat CT, but this time we did a CTA head and neck, which showed no acute intracranial process. There was no hemorrhage, no arterial stenosis, no dissection, and no thrombus anywhere. And then we actually did a lumbar puncture on this gentleman, and our CSF studies showed a glucose of 74, total protein of 40, 0 white blood cells, 1 red blood cell. The culture was negative. We ran some additional testing. The HSV, VZV, West Nile, enterovirus, Lyme, VDRL, and Cryptococcus antigens are all negative. There was a CSF ACE level of 2.6, which was borderline high. And then we also ran an MS profile, an autoimmune panel, and a paraneoplastic panel. They were all negative. And the flow cytometry showed no evidence of lymphoma. So I'm gonna leave you with that, and then the next aliquot is gonna reveal the diagnosis.
Great. Sorry, Sam, I didn't catch the last part that you said. What was negative for
Sorry.
lymphoma?
The flow cytometry of the CSF was negative for any evidence of lymphoma.
Got it. All righty. Maybe the Prof. we can dance about this one. So I think in terms of the CSF studies, honestly, like not pretty unremarkable to me. And the ACE studies, I often think about like ACE in a setting of like kind of sarcoids, which I mean, I guess sarcoid can do anything in neurosarcoid, but again, I think it's like very odd for it to present with like just affecting 3 cranial nerves. I still would want that MRI to kind of better visualize the structures. Because if I'm like, again, like I think still the question I'm trying to answer is that what causes 3 cranial nerves on the left to go out? And I think like a cavernous sinus processes, maybe infiltration, a little less likely, meningeal processes, maybe, which sarcoids fall under that as well. I think we ruled out like when it comes to meningeal, like a meningitis causing that. I guess sarcoid is a possibility, although I think that's all rare and will be my differential diagnosis. I think still for me, thinking about visualizing of cavernous sinus is kind of my no misdiagnosis in the setting of like the headache as well. But in so I think like that's honestly where my brain is going. What do you think, Prof. Raz?
Okay, so I did two things, Charmaine.
Okay.
One, I put in the problem representation to open evidence to ask
Yeah.
for an answer.
Mhm.
And then I used GPT 5.0, Robbie, to ask for an answer. And both of them, the first thing that came up was the Tolosa-Hunt syndrome.
Oh yeah.
Um, do you want to take it over? Because I
No,
don't
no,
know.
no,
Like,
no.
really, like,
That
what do you remember? Whatever you remember of it, Charmaine, is 10,000 times more than I remember.
I just remember it being like an inflammatory syndrome that affects like cranial nerves, right? That's all I
Beautiful.
remember from it.
It literally says this. It says, is a leading consideration given the subacute unilateral painful ophthalmoplegia without evidence of systemic inflammation for this like hidden behind the blood-brain barrier. This syndrome is characterized by granulomatous inflammation of the cavernous sinus. You mentioned the or superior orbital fissure presenting with ipsilateral headache and cranial nerve 3, 4, and 6 palsies, often with normal laboratory inflammatory and no systemic. Steroid responsiveness is typical. So Sam, we want to give steroids to this patient because we think they're in a steroid deficient state. And then it says, oh, also worry about the cavernous sinus. So anyways, imaging of the cavernous sinus and give steroids. Listen, I'm not afraid to give steroids on this platform. I've done it to a patient with Bartonella endocarditis. One gram I gave of methylprednisolone.
Preference just for our fun exercise. What do you make of that ACE level being elevated? Would like, do you think like sarcoid would be?
Oh my gosh, I love it because like we know that ACE is like really a marker of of well, non-specific marker of like granulomatous inflammation. So it's not specific to sarcoid. So I think it would be consistent with the hypothesis that it's like a granulomatous process. And like this specific flavor for me, Tolosa-Hunt,
Yeah.
unlike sarcoid, which is like lung and all that stuff, it just maybe it's a subset of that, but I think the ACE would be consistent with some kind of granulomatous process.
Beautiful. Beautiful. All right. This is what I love. Yeah. Like that's the thing about medicine. You know, more brain is always better than one. And Chat GPT is also another brain, you know? You just gotta know the right question to ask. I always say in medicine, if you can figure out what problem you're trying to solve and ask the right questions, you can always find the right answers. And Prof. Rez, ask the right question. And let's
We
see.
don't know if the answer is right yet, Charmaine.
No, but let's see if the answer is right. But the question is accurate. All right, Sam, teach us.
All right. So you're spot on, but Vale did beat you to it in the chat. Want to give her credit.
Let's go, Molly! Woo!
Woohoo! Of course you
Way to
did.
kick our butts and open evidence's butt. Let's go.
Yeah.
Let's go, Valley, our neurologist.
So the MRI and MRA, negative for ischemia, but it showed asymmetric dural thickening and enhancement of the left anteromedial cranial nerve fossa involving the cavernous sinus and extending superiorly towards the superior orbital fissure, which was a nonspecific finding. Consider granulomatous inflammatory tissue, in parentheses, the radiologist put Tolosa-Hunt, versus plaque meningioma. Our plan, you were again absolutely right. We started this patient on a high dose prednisone taper. It was 80 milligrams for 2 days, followed by 60 milligrams for 2 weeks, 40 for another 2 weeks, 20 for 2 weeks, and then 10 for 2 weeks. And then just because he was going to be on this really high dosage for a long time, we also started him on omeprazole and Bactrim for PJP prophylaxis. The headache resolved essentially immediately. And then he kind of gradually over time did regain his extraocular movements. He did have a little trouble when dropping the dose from 40 to 20. So his outpatient provider at that time has just kind of stretched out the taper a little. So he's now just decreasing by 5 milligrams instead of 10 every 2 weeks. But he's doing a lot better. He was able to see ophthalmology outpatient. And they put in their, I saw their note just today, doing much better currently on PO prednisone taper, exclamation point. And they concur with the diagnosis of Tolosa-Hunt syndrome. So feel free to enjoy that. I do have, if we want it a little extra teaching about Tolosa-Hunt if there's time because it's super rare.
Yeah, I would love that. I'm like literally reading about it as we speak, so would love to learn more. Yeah, tell us, Sam. Tell us the teaching.
All right. So Tolosa-Hunt syndrome, very rare condition, but it's characterized by recurrent episodes of unilateral periorbital headache with impaired functions of the nerves controlling extraocular movement. Sort of unknown etiology, but it does involve the granulomatous inflammation in the cavernous sinus and superior orbital fissure, and usually involves third, fourth, and sixth cranial nerves. Sometimes six is spared. Very, very rare. Accounts for about 3% of all cases of painful ophthalmoplegia. So it's a very narrow subset of presentations. It's very rare explanation for that presentation. Annual incidence is 1 case per 1 million people. Average age of onset is about 41 years old, and there's no known noted differences in prevalence by gender or by geographic location. This can hit anyone, tends to hit younger people. So usually people are going to present with some diplopia, maybe some ptosis. Occasionally there's also some trigeminal involvement. But this is a diagnosis of exclusion, so you have to essentially rule out all the other causes of painful ophthalmoplegia. But then the pain is usually going to resolve within 72 hours of corticosteroid treatment. And it does take a long time for the nerves to recover, typically. And then you can also get recurrences months or years later. But you have to rule out all of your neoplastic and infectious causes. And interestingly, like you've said, the CSF and sort of systemic inflammatory findings tend to be negative. And then I have a photo, I'll see if I can put it in the chat, of the cross section of the third cranial nerve for this, sort of looking at where here we go. I put it up. No, never mind. Didn't work.
You can share your screen,
Share my
Sam.
screen. Yeah. Yeah, so I think our sort of discussion at the time after we're kind of ruling out all these other causes was that these parasympathetics are sort of in this upper medial part of the nerve, and if just enough of those are spared, the pupil is still going to look normal when we do your exam.
That was such amazing teaching, Sam. Thank you so much, and what a great case. Definitely challenged my neuro knowledge, and I always appreciate that. And I learned more about the syndrome, so I really appreciate it. Professor, any thoughts before we pass along the
Yeah,
mic?
always a pleasure co-discussing with you. And I'm always like just blown away by CP Solver's attendees. Like Sam, like if you didn't tell me what year of training you were in, I was just listening to you present. I'd be like, this has to be a seasoned third-year resident. Like honestly, I mean that genuinely. Like where you paused, the information you shared, it's just such an outstanding job. And I think it's a testament to you, but also to just like the CP Solvers VMR mission. Like you guys are going to be so much brighter and smarter than we are. And yeah, and the last thing I'll say is that, that's it really does matter what you put into open evidence. Like knowing that like most causes of diplopia don't have a headache, so that already was unique. Knowing that most causes of diplopia doesn't involve all three knowing that is unique. Knowing the lack of systemic inflammation, so you still need the fund of knowledge. But with AI and fund of knowledge, oh my gosh, it's a scary, scary time. It's so exciting to be in medicine right now.
Yeah. As always, poetry. Beautifully said. Thank you so much, Sam. Ditto to everything Prof. said. All right, Mike. Thank you so much, Julia, for scribing. All right, Mike, to you, Amalpreet.
Thank you for the wonderful case and discussion. We have a few teaching points today. So let's dive into it. Initially, the patient came to us with the complaints of double vision. So we think about what is diplopia, how do we take proper history in that, and how do we diagnose what is happening. So diplopia, we have to understand if it is blurred vision or actually true double vision. And if it is blurred vision, we think about refractory issues. And if we confirm that the double vision is there, indeed there. So we have to confirm if it is in single eye or it is in the both of the eyes. How do we confirm that? We close one eye, and if the double vision disappears, that means that is a binocular diplopia, which is an issue of extraocular muscles. And if the double vision persists, that means that is a monoocular issue, and it could represent some intrinsic eye issue with the lens or retina and the other structures. So the patient presented to us with the complaints of diplopia and headache. No missed causes with these symptoms is an acute stroke, which is an emergency. Then if we dissect the headache, we always talk about primary versus secondary headache. Primary will be a diagnosis of exclusion here because it most likely sounds like a secondary headache with the presence of diplopia. So the combination of these symptoms with non-movement of one eye makes us prioritize a space-occupying lesion in this case. Therefore, we thought that this patient needs urgent neuroimaging, which was done, and the CT was normal. So then we start thinking about, because of the physical examination, that there is some issue with the extraocular muscles. So we start thinking of what cranial nerves supply those extraocular muscles. They are 3, 4, and 6. They have their nuclei in brainstem, and they get the input from the contralateral motor cortex. So any lesion in this whole pathway compressing the can lead to the problem and can compress all of the cranial nerves causing these symptoms. But we thought that it's a little odd that all the cranial nerves are involved, and only the cranial nerves are involved, nothing else is involved. So we were started to think about some other differentials, including the cavernous sinus. And we did not rely on the negative CT. We thought that we should get an MRI, MRA, and MRV to actually image all these structures to understand what is happening with these 3 cranial nerves. Then we discussed about some differentials like neurosarcoidosis, given the ACE levels, and Tolosa-Hunt syndrome. Both of them, they are granulomatous inflammation. So neurosarcoidosis is basically a form of sarcoidosis and is a long-term chronic disease of the central nervous system. But we ultimately diagnosed this patient as Tolosa-Hunt syndrome, which is a rare granulomatous inflammation condition of the cavernous sinus, superior orbital fissure, or the orbit. Tolosa-Hunt syndrome has a dramatic response to steroids. So would you prefer to give steroids in this patient, and the patient recovers in 72 hours. But the thing about Tolosa-Hunt syndrome is that it's a diagnosis of exclusion. So you need to rule out other important causes which can lead to the current presentation. And how does Tolosa-Hunt syndrome present? It presents as painful ophthalmoplegia and causes dysfunction of the ocular motor cranial nerves, as we saw in this case. So we need to rule out the other causes of painful ophthalmoplegia. And that's about it. And yes, the homework for today is we can read about the differentials of painful ophthalmoplegia. Thank you so much for the case and discussion.
Oh, that was brilliant. A great job. Wow. VMR is just the best. All right, everybody. Thanks so much, Sam, for the case. Thanks, Prof. Raz, for being here and teaching us so much. We'll see you all next time. Bye.